Yeah, now it's recording. Okay, so I will introduce you shortly because maybe some people don't know you. Dr. Sartipy is cardiothoracic surgeon in the Karolinska Institute in Stockholm, Sweden, and Dr. Dismore works in the same department. Please correct me if I'm wrong. You are a surgeon and you work currently doing research, right? Okay, sounds good. And I also see Dr. Glaser. You are one of the co-authors, right?
Right.
Okay, we are happy to have you here as well. So, yeah, Dr. Dismore, please start. You have all the time, and we are happy to hear you.
Okay, well, thank you so much, Leipzig, through Dr. Matteo Marin-Cuartas for inviting us, and of course, Professor Michael Borger as well. We are very excited that you took an interest in our latest article titled Aortic Valve Replacement with Mechanical Valves versus Paramount by Prosthesis in 50 to 69-year-old patients. This was published in JACC Advances this year, and was an interesting project to work on, I believe. Well, thank you for the nice introduction. I won't introduce ourselves much more, except I also mention Ruxin Liu. I think she might be next to Ulrik, is that correct? Who is the first author of this article. She's a medical student at Karolinska Institute, and she did this during an elective research course during medical school, and has since stayed on with us to continue high quality research. So we are very happy for that. And as you said, myself, I did my PhD under the supervision of Professor Sartipy and Glaser, and now have continued as a postdoctoral researcher. So currently I do no clinical work. I am actually stationed in Nairobi, Kenya for the moment, but still working for Karolinska with my old research group. Nathalie Glaser is resident in cardiology at Stockholm Southern Hospital. Let's say I can bring this up here. And was also previously a PhD student of Ulrik before becoming my co-supervisor. And Ulrik, of course, is a professor at Karolinska Institute and a senior consultant in cardiothoracic surgery at Karolinska University Hospital. So moving on to the study, I would like to start with a little bit of background. As you probably are aware, there is an ongoing debate whether mechanical or bioprosthetic valves is the optimal valve choice in patients aged 50 to 69 years old. Previous studies has had contradictory results, where some studies have reported a survival benefit with mechanical valves, whereas other studies have reported no difference. And of course, mechanical valves are dependent on anticoagulant therapy, and of course with an increased risk for bleeding. We believe these contradictory results has led to different recommendations in the European and American guidelines regarding the management of valvular disease, and more specifically the choice of type of prosthetic valve. The European guidelines has remained unchanged during the last two iterations. Here we see the 2017 guidelines, which recommend a mechanical valve in patients younger than 60 years old, an individual choice 60 to 65 years, and a bioprosthetic valve for patients older than 65 years. In the American guidelines from 2014, similar to the European ones, patients under 60 years of age were recommended a mechanical valve. 60 to 70-year-olds were suggested an individual decision, and patients older than 70 years old were recommended a bioprosthetic valve. However, Goldstone and colleagues published an article that showed the survival benefit with mechanical valves, but only up to 53 years of age, and after that, no difference. And this, well, most likely mainly because of this, they changed their guidelines in the 2020 version, so that patients younger than 50 years old were recommended a mechanical valve, and they increased the span from 50 to 65 years old as individual recommendation, and patients older than 65 years are recommended a bioprosthetic valve. And as I said, the European guidelines are still unchanged. Our group has previously shown that mechanical valves are associated with an improved survival in patients aged 50 to 59 years old. This is a study from Glaser, titled Aortic valve replacement with mechanical versus biological bioprosthesis in patients aged 50 to 69, which was published in European Heart Journal in 2016. This study included patients from 1997 until 2013, and we just did a propensity score matching to do this analysis. However, this survival benefit for mechanical patients disappeared in the subgroup of patients aged 60 to 69, and in that group there was no difference in survival. We have also previously shown that the Paramount bioprosthetic aortic valve has a superior performance compared to other bioprosthetic valves. This is in terms of survival, heart failure, and aortic valve reintervention. That is a new valve procedure or a transcatheter aortic valve intervention. The Paramount valve is also the most commonly used bioprosthesis in Sweden today and has been for quite some time, whereas the lesser performing valves, especially the mitral flow crown type of valves, has decreased a lot. This was shown in our study titled Comparison of Long-Term Performance of Bioprosthetic Aortic Valves in Sweden from 2003 to 2018, which was part of my PhD dissertation. So considering the results from these two prior studies, we decided to perform a repeat study. This would, of course, allow us to have a longer study period, as we could request new data beyond 2013, which was the previous study, and of course, provide a longer mean and maximum follow-up for patients who were in the earlier year of surgery. And of course, this would generate a larger study population with more statistical power. And most importantly, we believe this provides a fair comparison between mechanical valves and the best and also most commonly used bioprosthesis, which is the Paramount valve. And this makes it a more relevant comparison to clinical practice. The research question for this study was, can the best bioprosthesis outperform a mechanical valve for surgical AVR in patients aged 50 to 69 years old? The study population included all patients aged between 50 to 69 years old who underwent surgical aortic valve replacement in Sweden between 2003 and 2018. Patients could be included with or without concomitant coronary artery bypass grafting and descending aortic surgery. Patients were excluded if they had underwent previous cardiac surgery or a transcatheter aortic valve intervention, underwent concomitant surgery on another valve, had the use of deep hypothermia and circulatory arrest, or the use of any other bioprosthetic valve than the Paramount bioprosthesis. The data sources for this study included the Swedish Cardiac Surgery Register, which was used to identify the patient cohort. This is part of the National Swedeheart Register, which captures pre, peri, and post-operative data from all cardiac surgery clinics in Sweden and provides national and population-based coverage. Data from this study population was joined with other national health data and demographic registers, and the joining was made possible by the Swedish Personal Identification Number. Patients were, of course, categorized in this study according to whether they received a mechanical valve prosthesis or a Paramount bioprosthesis. The main outcome was all-cause mortality, and we also examined the secondary outcomes, which were major bleeding events in aortic valve reintervention, which could be either a surgical aortic valve replacement or a transcatheter aortic valve intervention, heart failure hospitalization, or stroke. We used regular Kaplan-Meier and Allen-Johansen estimators for analyzing through the time to event. For parametric analysis, we used flexible parametric survival models to model both survival and cumulative incidence outcomes. We used for confounding adjustment regression standardization. For those who don't recognize this method, it provides an estimate of what the population outcome would be if all patients in the population would have received either a mechanical valve or if all patients would have received a per-mount valve, respectively. This adjusts for the population distribution of covariates to remove differences between the groups. And this method can also provide an estimate of absolute effect measures, such as cumulative incidence or survival and differences thereof, apart from the relative effect measures, which we could get from the models themselves. So we identified 6,907 patients, 3,831 or 55% of the cohort to receive a per-mount valve, and 3,076 or 45% received a mechanical valve. There were some differences between the groups as expected, most notably in age, where patients who received the per-mount valve tended to be older than their mechanical valve counterparts. We also saw differences in prior bleeding events, where patients who received the per-mount valve tended to have a higher proportion of prior bleeding events, likely contributed to why they were chosen for a bioprosthetic valve. And also the period of surgery when they were operated. Here we can see that almost 46% of the patients were operated with a mechanical valve in the early era, whereas a bioprosthetic valve became much more common in the later period during the study period. This is also reflected here in this graph, which shows a trend in valve type use. And as we can see, the use of the per-mount valve has increased continuously during the study period, whereas a mechanical valve prosthesis has remained more or less stable, at least in the last decade, but has of course decreased since earlier periods, and especially if we would look even further back, mechanical valves were much more common. So for the main outcome, all-cause mortality or all-cause survival in all patients that is aged 50 to 69 years old, we found a significantly improved survival associated with the use of mechanical valves. They represent the red line up here, and the blue line underneath, of course, is the per-mount valve. This curve shows the absolute difference in survival between the mechanical and per-mount groups, and after 15 years of follow-up groups, this corresponds to an 8% survival difference. The significant difference in survival persisted in both subgroups aged 50 to 59-year-old and 60 to 69-year-olds. In the subgroup aged 50 to 59-year-olds, after 15 years, this amounted to a 15% survival difference. Whereas in the 60 to 69-year-olds, after 15 years, it only amounted to a 5% difference, which is also reflected here in these curves. But they are both curves do not cross the zero, which means this is a statistically significant differences. Not published in the original article, but added for this presentation, we did a spline interaction analysis between valve type and the spline model of age, as performed by the Goldstone article. And here in our data, we can see that mechanical valves might actually be beneficial up at least until the age of around 64 years old. The Goldstone article, if you remember, the lower confidence interval crossed somewhere around here, I think 53 or 54 years old. But this is what our spline analysis looked like. We also found, not very surprising, that mechanical valves were associated with a higher cumulative incidence of postoperative bleeding events compared to the bioprosthetic valve. And of course, much less aortic valve reinterventions. However, in heart failure or stroke, there was no difference between the valve type groups. So to summarize the findings, the mechanical valves were associated with an increased survival and increased risk of bleeding, and a decreased risk of aortic valve reintervention. And there was no differences in heart failure or stroke. The survival benefit was significant both in patients aged 50 to 59-year-old and also 60 to 69-year-old. However, the survival difference was diminishing in the 60 to 69-year-old group, whereas the increased risk for bleeding was pretty much the same between 50 to 59-year-olds and 60 to 69-year-olds, so remains constant across age groups. We believe that our findings support the current European guidelines that the mechanical valve should be considered in patients aged younger than 60 years old. However, we believe that they challenge the American guidelines due to the 15% survival difference observed after 15 years of follow-up in patients aged 50 to 59-year-old, which would represent the majority of this part. It is, of course, important to consider and to think about why the results differ. I have thought about this yet again in the last few days for this presentation, and I don't have a very clear answer, but there are a few key points that are worth mentioning. The Goldstone cohort was younger. The patients were younger both in the mechanical valve group and the bioprosthetic valve group. Since they are younger in both groups, it is not clear necessarily how this would affect the results, but it is an important note to make. Also, it has been shown that Sweden, and probably many other parts in Europe, has a very high time in the therapeutic interval for warfarin treatment, which is mandatory, of course, after receiving a mechanical valve. And this might increase the positive associations with mechanical valves in Sweden compared to the US. It is also possible that since the use of a mechanical valve is strongly associated with early surgical era or belonging early during the study period, it could be that an incorrect modeling of surgical era, that is how it is included in the models, if it is included linear per year or categorical per year intervals, or perhaps as a spline model, that an association that is more tied to the surgical era is wrongfully interpreted as a negative or a decreased effect of the mechanical valve. This is just speculation, but could be a mechanism behind the difference in results. To conclude, we found a substantial survival benefit associated with mechanical valves in patients aged 50 to 59 years. These results suggest that it may be prudent to adjust current American guidelines to recommend a mechanical valve for patients up to 60 years old aged, as is current in the European guidelines. And that is it. Thank you very much.
Great. Thank you very much for the presentation, Dr. Dismore. You really did a very good summary of the paper. I do have some questions, but sorry, I muted myself. I do have some questions, but maybe somebody else in the audience has any questions. I don't know if somebody else wants to start asking something. Okay, so I can start. I mean, you kind of already mentioned that the time. I mean, you saw an advantage of in mortality for patients with mechanical valves, and you actually mentioned that maybe one factor was that let's say most of the Sweden patients are very compliant, so they are kind of they have a good follow-up, they have a good INR. So my question is, and by the way, you have in your paper in the first table, it's very interesting because you show the level of education of the patients, and this is actually it's not common to see in a paper, so I actually like that. And I see that actually most of the patients are very well educated, like 45% of the patients 10 to 12 years education, and 25% of the patients more than 12 years, so they are quite educated. So let's say the Sweden population are the easy patients to have with mechanical valves. What do you think about the rest of the world? Because, I mean, in Sweden, in Germany, in Europe, you can have a mechanical valve because you can go to the doctor and have your INR checked or do it at home, and it's easy. But actually, the patients who have even more benefits from a mechanical valve are those who cannot go to the doctor because they live somewhere very far away from the nearest city. So what do you think about your results extrapolated to another, let's say, not European society?
Yes, absolutely. And as you were saying, we are very lucky to have our registers, the education level, as well as household income, and all of this demographic data comes from the Statistics Sweden, which provides very high granular level information on an individual level, which of course makes it possible to include this data in our models. Other studies from our group have shown association with worse outcomes associated with low socioeconomic status, either defined as household income or also education level. And it is very possible, as you were saying, that it might be a problem with generalizability to take this result and assume it will be the same in America, because there might be other factors at play, but it could very well be so that the populations differ so much that it actually is prudent to recommend the mechanical valve in a younger cohort in the US, and of course many other parts in the world compared to Sweden, due to factors, socioeconomic factors, but also access to healthcare and regular follow-up. So that is definitely something that needs to be taken into consideration before really adopting guidelines based on these results in other populations. Definitely. I think you are muted.
Yes, sorry. I do have one more question, and thank you for the previous answer. I mean, we saw that the stroke rates and the heart failure rates were similar, and the mortality was better for the mechanical valves. And of course, as expected, the bleeding rates are higher for the mechanical valves. But we see that the mortality rates are higher in the biological valve group, basically because of the redo or the reoperations. Like it has the highest burden, let's say. So I saw in your paper that the redos were somewhere surgical replacement as a redo operation, and some of them were TAVI as a valve-in-valve procedure. Do you have information about how much or how many patients were a TAVI procedure, and how was the mortality? Was it comparable to the redo SAVR, or was it significantly better? Because actually, like, TAVI is now a reality, and it's actually one of the options for the redo procedure, and it's part of the, let's say, lifetime management of aortic disease. So I will think that patients, like maybe if they are like in their 60s, they can get a biological valve, and then if they survive like 15 years, then they get their TAVI, and they're already 75, almost 80, and a second procedure with a TAVI should be enough until they die. So do you have any results in this regard?
Unfortunately, no. I mean, I have the data, but I have not analyzed it, so I haven't prepared anything I can show you. All I know is that, of course, the valve-in-valve procedures with TAVI is non-existent in the early year, or if you go back a few years, but in the late years, it's increasing a lot. Regarding outcomes for those, I'm not sure. Natalie, do you have any recent results or can comment on the valve-in-valve TAVR?
Sorry, I haven't. I will have, but not at the moment.
Okay. It is a very interesting question, and it would be worth digging into a little bit deeper. So if I find something more, I'll be happy to email you, Matteo, with an answer.
Well, we are looking forward for the paper to see the upcoming publication.
Exactly.
Yeah, Adrian, you have a question.
Yes, thanks, Matteo, and thanks a lot, Dr. Dismore, for the very nice presentation. So I just maybe one comment and one question. So just commenting the point of Matteo about the level of education, I just wanted to emphasize this point. So I worked for 6 months in Egypt, in Alexandria, and we saw like monthly cases with a stuck valve, because there are a lot of rheumatic mitral valve disease, and the patients get a lot of mechanical prosthesis. And the word stuck valve as an acute emergency procedure in the cardiac surgery, I have never heard about it in Heart Center Leipzig since I moved and I worked there. So that's a very important point, and it should never be ignored when choosing the prosthesis for the patient according to his or her compliance. So the question regarding the endpoint of bleeding, what was the definition of bleeding? Like epistaxis would be considered as bleeding as well as intercerebral hemorrhage. Are they equally considered as bleeding, or what was your definition of bleeding in your study?
So it was defined as a major bleeding event, and the bleeding events were identified using ICD-10 codes, basically from our in and out patient registers. Let me see here if I have a table with the actual codes. 1 second. Yes, so here I will share you again. So these are the ICD code definitions for the various outcomes. I am afraid I don't remember the bleeding codes on the top of my head. Ulrik, do you have any more?
Yes, probably you should mention that major bleeding is defined in this study as hospitalization for a bleeding event. So even though it's like a minor nosebleed, if you had to go to the hospital, then it's a major bleeding event. So all bleeding events are patients admitted to the hospital due to bleeding.
So my question would be the next question. Wouldn't it be more interesting data not to have the bleeding causing hospitalization, but bleeding that affects the quality of life of the patient? So like, which is very important to know, like gastrointestinal bleeding causing acute hemorrhagic shock or intracerebral hemorrhage, like this kinds of bleeding that actually we're afraid about for older patients. And that's why we do not recommend for patients that are older than 75 years old or 69 years old a mechanical prosthesis. So that would be very interesting to know what was the incidence in this group of patients, because I think this would be very effective in the simple consent taking for the patient and asking him which prosthesis he needs. This information would help us a lot in the decision making. What do you think?
Yes, absolutely. I think this is a problem. I mean, there are many benefits by using our large registries because we have a lot of data for very many patients with very long follow-up. But this type of studies tend to miss, as you were saying, sometimes more softer outcomes, especially related to quality of life. That is hard to measure in automated captures in health registers. But that is a very important point, and definitely important for patients, and therefore, of course, important for clinical guidelines. I will show you here just again. So these are some supplementary slides. So these are the outcomes in the older patient category for the secondary outcome, 60 to 69 years old. And here you can see the incidence of bleeding. And as you can see, it is quite high. For a mechanical valve, the point estimate is 15, I mean, approaching 20% for a severe case of bleeding. And I would assume that most of these cases, of course, have a negative impact on quality of life. But for sure, there are many bleeding events not captured by this that still has probably detrimental effects on quality of life as well. So that is an important point, definitely.
Thank you very much.
Thank you.
There are a couple of questions in the chat. I can read them. One is, well, thank you for the presentation. And may I ask which mechanical valves were used? Was the ONX valve with lower INR levels recommended as a therapeutic option? Well, I mean, this study was only with Perimount, right?
Yeah, so I will show you here. Let's see. I think I have it here. Yes, so this is the frequency of the different valves used. And of course, the bioprosthetic valve is limited to, well, the group Paramount. So this could be the regular Paramount 2900, the Magna Ease, and a few where we weren't able to sub-classify the type of Paramount. But for the mechanical valves, there were definitely ONX. This ONX is just an internal code for how we could identify it. So there are more ONX than these 5. Here we can see it is about 220 patients with the ONX valve. The most common one being the Carbomedics reduced. So a much more disparate group of different valves used. Did that answer the question, or was there something I missed?
Yeah, I think that was the answer. Yeah, sorry, I was confused for a second, but yeah, you're right. And do you know the INR level in the ONX group? You probably don't have that data, right?
I don't have data. I mean the actual what they actually had. You mean?
Okay.
What do you mean the guidelines in Sweden?
Yeah. Okay. And there is another question here. A great talk. Thank you. I guess enormous field for improvement in anticoagulation methods. Novel agents needed to replace Coumadin. My question is, what do you tell your 50-year-old patient with aortic stenosis who tells you she wants a tissue valve? Do Swedish patients accept mechanical valves? Like, okay, like how do you have this, let's say, conversation with your patients? How you choose your valves?
As suggested both in European and American guidelines, end of the day, this is an individualized decision, and of course, patient will is, the top priority. But we tend to provide the patient with understandable and as correct information as possible. And I mean, of course, these kind of studies can show them the risks of going with a bioprosthetic valve in that age category. Some patients, although very few, insist upon having a bioprosthetic valve, and if that is what they demand, then that is what they will get, but only after we feel that they have been properly informed. I don't know if Ulrik want to add something, who probably have this discussion more than I have had recently.
Yes, I agree with Michael, but to answer the last sentence in the question, do Swedish patients accept mechanical valves? Yes, they do. Younger patients below approximately 60 years of age usually accept mechanical valves. And part of that, part of the reason that they do that is that the quality of warfarin treatment and control is high in Sweden, and patients are not that afraid of warfarin and accept anticoagulation treatment generally.
And also, I'm not sure how it is in the rest of Sweden, but at least in Stockholm, we have quite a functional home testing program for self-management of INR. I don't know how that is in other parts, but I think that might be a reason, at least for Stockholm patients, to not be so burdened by warfarin treatment.
Okay, great. Well, are there any other questions from the audience? Somebody else has any other comment?
Yes, maybe one last comment. So just an idea that came to my mind hearing the discussion. So why we use the Hasbled score and the Schwarzbach score to decide for atrial fibrillation if the patient has high risk for anticoagulation or not. But we do not do that when we are deciding actually a lifelong decision for the patient, which prosthesis do we put. So is such scores are used in Sweden for such decisions or not?
They're not used for valve choice, but I mean, they're definitely used for atrial fibrillation. Ulrik, you wanted to say something?
Yes, no, you're correct. For starting anticoagulation for atrial fibrillation, of course, we use the Schatz-Vask scores, but in the discussion with the patient, we do not use the has-bled score or other bleeding risk scores. But I mean, you do that kind of calculation anyway. And of course, we do not recommend mechanical valves that needs lifelong anticoagulations to patients that has a high bleeding risk.
Thank you very much.
Paulina, do you have a question?
Yes, thank you for the presentation. And my question is, if you maybe consider to include a myocardial infarction as one of the outcomes. We did a similar study in Colombia, but we just have like 5 years follow-up that for us, it wasn't enough years follow-up to see these differences. But we saw like a tendency in biological valves and heart infarction, but we don't have like enough follow-up. Then that was my question.
Okay, that is interesting. It's not something I have heard before. I mean, we of course have data available for myocardial infarction outcomes, so it would definitely be possible to study in this cohort as well. But I have not looked at it, so I can't tell you how it is in our material.
Okay, thank you.
Okay, well, I think there are no any questions. So I think that's it. I think we're done. Okay, yeah, thank you very much for the presentation and for your time for presenting this and for preparing the presentation. And thank you for joining. Like almost all the co-authors joined. That's cool. Yeah, happy to have you here. Oh, by the way, I forgot this at the beginning. I have to apologize my boss, my department's director, because he had a parallel commitment, a simultaneous commitment, so he could not join. But yeah, he sends you his best regards and apologize for not joining.
Okay,
Thank you so much for the invitation.
Very nice and interesting discussions.
Thank you so much for the invitation.
We thank you. Thank you very much, and hope to see you soon. Bye-bye.
Thank you. Bye-bye.
Bye.